Hello and welcome to Arbor Rehabilitation's brief webinar on home health documentation. I'm Cindy Hudson. I'm the Director of Clinical Compliance, and I want to thank you for your time and attention this afternoon. So we're going to talk about some strategies for success with home care documentation. And oftentimes people wonder who cares, who's really going to be reading our notes. And I will say at this point in time, there is a big audience for our documentation in the home care arena. Each agency cares what we're writing. They do review our information. So we want to make sure that we're communicating clearly and accurately for the agencies that are reviewing our information. The state cares. In the state of Ohio, we are one of the review choice demonstration states, which means that 100% of our claims are being reviewed by the state. So again, the quality of what we put down could impact the reimbursement to the agencies, which then would impact our relationship with that agency. We want to make sure we're putting our best foot forward with our documentation. In addition, attorneys are going to care. I don't think I need to say a lot about that, but again, should something go to litigation, we want to make sure that we've got very clear, accurate information documented. And in the long run, it's going to protect your license, much less certainly the clients that we serve. So again, documentation is critical for a lot of reasons. When we look at the overall picture with documentation, we want to make sure that what we write is going to support the need for the sophisticated care that we provide in the person's home. From the reason for referral and the evaluation to why they're homebound and everything that happens in between and why they continue to need our skills, we want to make sure our notes clearly reflect that information. We're going to start with the evaluation because the very first section that we look at is that reason for referral, or in Therapy Boss, it's called the reason for evaluation. And there we need to explain what happened, what's changed, why they need our particular therapy now. If we can relate some functional changes to their medical condition, that makes for a stronger claim. And using the verbiage for the treatment diagnosis and relating to why your discipline is necessary strengthens the claim. And we want to link any functional need for therapy to that medical and treatment diagnosis. So for example, an individual might have had an exacerbation of COPD, which has resulted in decreased mobility, increased weakness, and increased risk for falls. Therefore, physical therapy evaluation is indicated. Makes it extremely clear what's been going on, linking those medical things to the functional changes and the need for physical therapy in that example. Looking at the big picture, we want to show the interaction of comorbidities as well, because we know that the more stuff individuals have going on, the more complicated their rehab picture looks. Same with the duration of the condition. If somebody's had an ongoing issue for a while, that shifts our outlook as well for that individual. And so we want to look at their clinical course of either progressing or declining, looking at their overall prognosis, looking at their functional limitations, and what else has been going on. So in the bottom of this screen, you see an example of somebody who maybe has had a 4-month history of worsening CHF that's resulted in weakness and decreased independence with ADLs. They attempted outpatient therapy, but they were unable to participate due to increasing shortness of breath. Now presents with weakness, ADL decline, and therefore need for occupational therapy. Okay, that's one possible example of a very solid reason for referral. We also need to be very clear in documenting the homebound status. Why are they homebound? It needs to be evident and consistent in all of our documentation, not just in the evaluation, but in each visit note as well. So we need to use specific measurable terms to define why they're homebound. Just clicking on the boxes, sometimes some of our EMRs, our electronic medical records, have some boxes we can check off to defend the homebound status. That's a good start, but that does not individualize it. It does not really prove, well, this person versus that person is in a homebound situation. So if we can say things like they can walk 10 feet before shortness of breath, that they're not able to transition very comfortably without extreme pain, all those kinds of things might impact why they are homebound. If someone's confused, you want to describe what the risks could be for somebody confused being out and about in the community. So again, there's sometimes some issues if a person has a degree of dementia that's making them homebound as well. Make sure you explain that, okay? Moving on, we're going to talk about the CMS definitions of homebound. It's criteria 1 and criteria 2 that the person has to qualify. So with criteria 1, they need assistance, either the assistance of another person or use of an assistive device to leave the home, or they have a condition that would make leaving the home contraindicated. Maybe somebody who's pretty immunocompromised should not be out and about in the community. That's criteria 1, and they need to meet criteria 2, which says that there's a normal inability to leave the home and leaving the home requires a considerable and taxing effort. So all of that combined, there's some variables, but all of that combined is necessary for the person to qualify as homebound. With the evaluation, we want to note the past medical history pretty carefully, describing the prior level of function, looking at the environmental factors that influence what's going on, looking at the behavioral habits that could impact what we're doing, and then any kind of client quotations that we can have to support our findings that would support that homebound status. You know, they maybe say I can walk 20 feet, but it sure really makes my heart race or makes me feel a lot more pain. Those kinds of quotations can help support what we're doing as well. With the past medical history, especially as it's impacting the current situation, we want to highlight that information. So if they had a hip replacement, 3 months ago, and they may be pretty much rehabbed from that, but they still have some soreness or some pain with steps. Even if we're seeing them now for an exacerbation of COPD, for example, but that history of the hip surgery can impact our clinical picture. Make sure we describe that. Looking at their prior level of function, we need to support why we think our goals are reasonable ones. So it isn't so much based on time frame, but where they're at now with their whole rehabilitative process. So if 2 months ago they were independent, we think that's reasonable, then we would choose that as our prior level. If 2 months ago they were max assist, but 3 months ago they were independent, again, we might look back at that 3-month range if that's appropriate to support that independent level for our goals. Looking at the environment, looking at the things that it can impact how that person's functioning. If there's a smoker in the house, but that individual has CHF, that makes it kind of more complicated. If they've got a lot of trip hazards like toys or small pets, those kinds of things, uneven carpeting, that's going to contribute to their overall independence and safety. When we're looking at the social and behavioral habits, for example, what's their level of cooperation? What's their buy-in with this whole home health care process? Remember, and this is a little bit of a side note, when we're looking at that evaluation, we do need to get out there within 24 to 48 hours of the start of care to complete our assessments. Those orders in home health are only valid for 5 days. So if for whatever reason, with holidays coming up and what it might be, that you cannot get out there within 5 days, we do need to have a new order. And anytime we're not able to respond as quickly as we would like, we need to document that in the EMR system that we're attempting to contact, unable to schedule for whatever reason, but make sure you explain why we're not meeting that 24 to 48 hour criteria. Looking at the systems as we're doing the evaluations, making sure we're checking vitals, looking at objective and standardized tests, making sure we've got a treatment diagnosis that's going to support our plan of care, and making sure we're painting a consistent picture throughout all of our documentation. When we set goals, they need to be client-driven or caregiver-driven on behalf of the client. We want those goals to be measurable and objective, of course. They need to be related to function. So if we're going to have a goal for strength or range of motion, it needs to be able to improve gait or upper body ADLs or whatever it might be. Sometimes as I audit charts, I see goals for things like, therapists to assess patients' ability to do something. That is not necessarily a patient-driven goal, that's a therapist-driven goal, and not really appropriate in this setting and really in the SNFs and many other settings. So again, everything almost needs to start with patient will, patient to, and then it's going to be a patient-driven goal. You want to quantify what you want to see as a result of your therapy. And sometimes it can help to put things in terms of percentages. You want that person to be 100% aware of their home exercise program. So that way, when we're showing little bits of gains, they're 50%, they're 60%, 70%, we show that we're inching towards that 100% awareness of a home exercise program, as an example. Percentages can give us that leeway to show small gains. You can also say good, fair, poor, but sometimes there's a little less, documentation wiggle room in there. When we're setting goals, we want to make sure that we make home exercise programs a part of all plan of cares as much as is clinically appropriate. You want to make sure that your time frame is consistent with your treatment plan and your diagnosis. So for example, you don't want your goals to be achievable in 8 weeks when you only have a 4-week plan of care. That wouldn't make much sense. And also you want to make sure it's consistent with the diagnosis. So if you've got somebody with a total knee replacement and they're coming in pretty much at a contact guard assist level with mobility and ADLs, it wouldn't be reasonable for having them on an 8-week plan of care necessarily, especially if they're a traditional Medicare A payer. Some of our agencies do recommend that we do write an 8-week plan of care for the managed care folks, because it can take a couple weeks to get that authorization in. And that way we have some wiggle room We don't have to go do a reassessment right away. But again, make sure that your documentation is going to make sense with your treatment plan and the diagnosis, especially with the traditional Med-A folks. You want to also document client involvement in goal setting. So that's obviously an important thing as well. To rewind a moment, when we're looking at the time frame, you don't have to specify a date, but you do need to specify 2 weeks, 4 weeks, 6 weeks. So if you want them to be 100% aware of a home exercise program in 2 weeks, that is adequate. You don't have to specify a date, okay? We do also want to be careful that we're setting goals that are going to be realistic and reasonable for that individual. With additional evaluation tips, we want to look at the accurate frequency and duration, remembering that a week for most of our agencies is Sunday through Saturday. So if you evaluate on a Wednesday and you're not sure the CODA is going to get out there or the PTA is going to get out there, it would be a 1 week one and then 2 week two. And again, being careful on the other end, if you have them on for 2 week 4, by that 4th week, the assistant can only do 1 visit, and then the evaluating therapist needs to do the 2nd visit to do that discharge or reassessment to follow that 2 times a week frequency specification, okay? We want to document coordination of care and physician contact. Make sure that you include with where you document this, the time and the date of the phone call to the physician's office and with whom you spoke to let them know that they're going to be on speech therapy 2 week 3 or whatever it might be. We cannot leave messages on an answering machine for that initial evaluation information. Our OASIS items need to be congruent with our evaluative findings. I think that only makes sense. And that assessment summary in our documentation needs to show the impairments with some supporting evidence as to why our discipline is indicated at this point in time. Moving on from the evaluation to our daily visit notes, we want to have it be factual, just the facts, Jack, and what we put into our notes. And we can include client statements. Again, that only better supports what we're doing. If they say, I can get out of bed easier now, that's really good information to show the impact of what we're doing for our people. We want specific, unique, and measurable terms for why the person is still homebound and why they still need your skilled services. So like I said before, if we can say things like, they get short of breath walking 10 feet, continue to need safety education for transfers, that's going to support what we're doing. We need to document follow-up on any kind of changes in condition. So don't just document that they have increased pain, document what you're going to do about it. Did you notify the agency? Did you remind them of some simple stretches they can do to alleviate pain? What are you doing about that report of increased pain? Also document any of the complaints that they have. Definitely let your program manager know and or let the agency know of any complaints that you hear. And then when issues have been resolved, make sure you note that as well. Sometimes we leave the readers hanging if we don't document our follow-through that we may have in fact done. Make sure we've got compliance, as I said before, with the plan of care frequency and duration. And with Therapy Boss, those who are documenting in that EMR, Therapy Boss and their interventions is where you're going to describe your skilled services and the person's response to what it is that we're teaching and training. Also, just to let you know, with First Choice, one of the agencies we work with, when we're waiting for authorization prior to initiating treatment, the program managers are going to be kind enough to put in some missed visits for us so that when we've got an evaluation done, we're waiting on authorization, know that those program managers are going to be kind enough to enter missed visits. But as soon as we have authorization, we need to make sure that we're being careful about that frequency and go ahead and schedule our treatments and go forward with that plan of care, okay? With the daily visit note, also make sure you document any kind of incidences, falls, medication changes, increases in pain, like I said. Even if you did not witness the fall, but the family reports the fall happened last night, you do need to do an incident report documenting it as an unobserved fall and then document what the person is telling you about that situation. So make sure you fill out an incident report for that. Make sure you're taking vitals pre and post session, especially for our folks with cardiopulmonary issues. We want to make sure that we're showing they were okay when we began, we did our magic, and they were okay when we left that therapy session as well. And the best way to do that is with objective information. Tell us the blood pressure, tell us the pulse, the respirations, SpO2, temperature, and all that good stuff, okay? We want to compare the progress from the last visit to today's status, doing any kind of objective retesting when it's appropriate, and then making sure we're still objectively describing why that person might be homebound. And just to clarify, going back to our first bullet point, by the way, an incident is any event that is not part of routine care. So somebody sliding off the bed to the floor, I would hope that that's not part of their routine, so that would in fact qualify as an incident. Near falls qualify as an incident. For you as a therapist, any kind of accidental exposures qualify as an incident. Make sure you're filling out an incident report. Those are in our EMR systems as well as on the Arbor website. When we're looking at the daily visit note, a little bit more information about that. I've got our Arby's hat there because we want to think about the meat of what we're doing. We want to think about the skilled interventions. Under that interventions tab in all of our EMR systems is where we show the good stuff that we bring to the table every day when we're treating people. We need to show them the meat for our time that we're spending with that individual. If I see one brief intervention, they walked 10 feet with MinAssist, and yet you were in the home for 40 minutes without any other information being provided, that doesn't look so good. So make sure you're supporting the time that you're there with your information, recapping the tasks that were performed, recapping the status, noting a discussion of any discharge information you might be sharing, and then make a specific plan for your next visit. When I review charts, sometimes I see plan as just per plan of care. That's not telling me that you've used any clinical judgment to say, you know what, we're ready for trying steps now. We're going to focus on lower body dressing, whatever it might be. You do need to be specific. In Therapy Box, there's a section called Progress Towards Goals, and I would expect to see information there. Are we starting to show gains in the direction we want to go? And if we're not, why not? There's another section for noting any kind of goals that are achieved. Again, make sure you're aware of that plan of care, what the goals are, and document anything that might be already achieved. Again, the Arby's recipe for good documentation is going to be to describe and quantify the mobility of the ADLs or the swallow deficits, communication deficits, describing what's going wrong, and then explaining what you're trying to do to help it go right. So what goes wrong? What are you doing to help it go right? So what are you attempting to do to reduce those deficits? And it needs to be something that the average person off the street wouldn't know how to do. So you need to explain what took your wisdom or your smarts to make that session be successful for that individual. And then real important is to document the person's response to your interventions. Did they say, yeah, I'll use a walker while you're here, but I'm never going to use it when you leave? Or are they saying, this is wonderful, I love the sake, it makes it so much easier? Document the response, document how well they're doing with the training that you're providing. Okay, so again, if you're going to be describing things related to OT, you might need to be specific and discuss that they've got limited internal rotation, which is making toilet hygiene very difficult for this individual. Therefore, you're working on right shoulder internal rotation to enable toileting hygiene. Really specific, really clear that it took your smarts to analyze what's going wrong and then addressing what you need to do for it to go right. Maybe somebody has decreased step height. And so for today, you had them walking, stepping across small pillows. And you're doing that small pillow step to increase step height or increase their step length. And if they did that well, they didn't step on any pillows, maybe they did good follow through with the step height activity. So again, those are some things that you might want to think about. You know what you're doing, make sure you explain it on paper. Make sure you describe any kind of compensatory techniques or strategies. Sometimes I'll see notes and they needed min cues for proper technique. They were instructed on compensatory strategies. Tell me what? Tell me what kinds of cues, what kinds of techniques were you instructing? What kinds of compensatory ideas did you have that would help them be successful? Be more specific. If you start your sentence with words like adjusted or taught or instructed, upgraded, downgraded, educated, all those words that you see on the screen will help you trigger skilled information. With therapeutic exercise, it's also really important to explain why it took you providing that portion of the session. Why can't the individual themselves do a self-exercise program? Why can't the caregiver follow through with an exercise program? You need to show what took your skills for that portion of the session. Did they need cue for full range of motion, proper muscle isolation, pacing, breathing techniques, all those good things and more? Why is it that you're providing that portion of the session? With skill documentation, you also want to show the sophistication or the smarts of what it is that you're doing. So for durable medical equipment, okay, if they have that need, make sure that you connect with either the program manager or Annie Harris to get additional information about how that is ordered, because it does vary depending on the agency, depending on the payer source, depending on the item that you're looking at. So again, when we have those needs, make sure you reach out for some help. Make sure that you're treating per the plan of care only, okay? It's real easy sometimes to start addressing other needs. When you look at the plan of care, if you don't have a goal for that, you are working out of your scope of practice and you don't want to do that. So make sure you're only treating for the plan of care. And if it's reasonable, you can link what you're doing to that plan of care goal. So if you've got a goal for transfers, but you have to work on bed mobility to get them to be able to transfer, very clearly document that you address bed mobility to prepare for transfers, that type of thing. Also, making sure that you're not repeating the same information. Sometimes I read some really good skilled notes, but I see that same few phrases used day after day with that individual, person after person after person. It's less individualized, it's less progressive in nature, and not been so skilled. So make sure you're showing the different information that you're doing each day. With physical therapy, make sure you're defining the gait deviations, the abnormal patterns, and what you're doing to correct them. Note the results of your training. Make sure you're specific about the distances they're going, what device you're using, what kind of surface they're on. Maybe they can upgrade to an uneven surface as opposed to a level surface. Note the type of transfer. Is it a low bottom transfer, sliding board transfer? Note the equipment that you're using, what you're doing to improve transfer skills. I don't want to read for any discipline just a status report. Oh, they dressed uppers with mid-assist, they walked 10 feet with mod-assist. That doesn't tell me what took your smarts. So make sure that you're showing what you're doing to improve their abilities. And then again, document the client response. With OT, make sure that you're noting some specific modifications or recommendations. So again, if you're modifying the environment with the person's permission, that you put their nightstand in a different location for easier access. Are you leaving their blouses buttoned up so they can put them on like a pullover? Those kinds of things. What are you doing with equipment? Be specific. Is it a soft sock aid, rigid sock aid, dressing stick? Don't just say you trained them on adaptive equipment. Tell me what, and tell me if it was successful. You want to show your task analysis that you're doing to help break down the activity and enable better success. So again, are they doing backward chaining? Are you addressing problem-solving skills to better carry over during ADLs? Again, documenting the effectiveness of any adaptive equipment, noting their specific response to that, okay? Reassessments, those are due in 30 days, we know that. We want to retest relevant areas so that we can show the gains or the remaining deficits and why ongoing home-based skilled therapy is indicated. Contrast their status with what you found on the evaluation, and make sure that you're being very clear about justifying why ongoing home-based skilled therapy is appropriate. With reassessments, you also need to update the goals as necessary, note the status towards each goal. You might need a new physician's order, and you want to strongly justify why the person still needs home-based therapy. With our forms, make sure that we have a consent form that's been completed upon the evaluation. All of our clients should have a folder in their home from whoever did the open, and there should be a signed consent form in that folder. Also, prior to discharge, well in advance, like usually at least a week in advance of discharge, we want to get the notice of Medicare non-coverage form signed. That's oftentimes housed in our EMR systems as well. So you make sure that you check out those forms, know when you need to do them, and if you've got questions, certainly reach out to the program manager or myself, and we would be happy to help you locate those forms for different agencies. So some additional pointers: make sure that you explain your abbreviations. All documents are to be done in a timely manner so that we have our best accuracy. We've got solid, timely team communication happening. We need to be treating consistently with the severity of the condition. We've talked about that. Sometimes it's appropriate to titrate down the intensity. They might start out at 1 week 1, 2 week 2, 1 week 2, kind of titrating them down to make sure they've got that carryover going on. With our time in, time out, that needs to be exact. That needs to not be rounded. It doesn't seem really accurate that every day is an exactly 45-minute treatment session. So if you got there at 11:03, you leave at 11:49, that type of thing. It's more likely to be accurate. Don't round your time, okay? Make sure that you've got your notes done at the latest. If it's a daily treatment note, make sure you've got that visit note in at the latest by the next morning from your visit. Ideally, they need to be done that day for best accuracy, but certainly no later than the following morning. With the evaluations, they need to be done in at least 24 hours, if not sooner. You need to alert nursing if the medical diagnosis seems incomplete or inaccurate based on your findings. If you look at the chart and it says they've had a right total knee replacement, but you're seeing staples on the left side, make sure that you alert nursing so that we can get that information clarified. It's going to be really important at this point in time that we work with our agencies to help reduce their rehospitalizations, because agencies are going to get penalized if they have a high rate of people going back to the hospital. It looks like they're not taking very good care of their folks. So that ends up in a penalty from CMS to our agencies. So we want to make sure that we're working in tandem with them to reduce the risk of rehospitalization. We need to focus on patient training, caregiver training is appropriate. We want to use the zone tools. Those are those disease management education tools that are written in very family-friendly terms. They're not in big professional jargon. We have stop and watch forms. Those things are all on our website. Falls prevention, all the information is available on our website. So we can help print them off, take them with you on select visits, make sure that we've trained people to keep themselves healthy, keep themselves at home, okay? Make sure that with our, again, as I said before, with our cardio folks, make sure we're teaching them about their vitals. When is it okay? When is it not okay? When do they want to alert the nurse? When do they want to call the doctor? Call 911. State's looking for us to avoid duplication of any kind of services, so make sure you've communicated who's going to do things like bed mobility or medication management. As of January 1st of 2019, so this has been in place for a while now, we have outcomes reporting that's necessary on 23 different possible areas. That's known as Section GG, part of the OASIS. So again, you may be asked to provide some information along those lines as we move forward under PDGM, which is coming up January 1st of 2020. With infection control, word on the street is that the surveyors are looking at infection control as a focal area. So make sure you're familiar with the bag technique. If you're not, we have resources for that as well. So make sure you've got that in mind. Great closing words. We want to make sure you know arborrehab.com is our website. Register to use our employee portal. On the left-hand tab under the home health area, there's a whole section for home health resources. There's a lot of other forums, program information. Help yourself to look around there. There's a lot of good information. And you have contact information as well on this slide. Annie Harris, myself, Summer McCormick, our program manager, and Ashley Matthews, another program manager. Their email addresses would be summerm@arborrehab.com and ashleym@arborrehab.com. Thank you for your time and attention. Hope you have a great rest of the day.